gives me great pleasure to introduce Dr. Sarwat Umer for a grand round. Her topic, she's the Associate Professor of Medicine and Rheumatology, and she's the only pediatric rheumatologist. And her topic today is IgG4 related disease, which is a very relatively new disease, and she'll tell you a lot about it. IgG4 disease and the great mimicker.
Thank you. Hello everyone, thank you for coming. I'm going to get started. We're going to talk about IgG4 related disease, the great mimicker. I have nothing to disclose. The objectives of my talk are that we should be able to define IgG4 related disease after this lecture. We will talk about the various clinical manifestations of IgG4 related disease. We should be able to diagnose a patient with IgG4 related disease and design an appropriate management plan. And we will discuss the role of various immunosuppressive agents in managing IgG4 related disease. I'm going to start with a case. I would say that in the last 7 years, I have treated 4 cases of IgG4 related disease, and they all had very diverse or various manifestations. So we'll start with this case. 34-year-old female with history of sinusitis who presented with worsening sinus symptom and new onset diplopia. She reports symptoms in the morning when she wakes up associated with constant pressure behind her right eye. She also had history of transient blindness and white flash in the right eye when laying down on the right side. She reports right-sided headaches which worsen over the course of the day. She denies any fevers, chills, nausea, vomiting, epistaxis, blurry vision, arthralgia, myalgia, paresthesia, weakness, and seizure. So the visual symptoms, as we say, the blurry vision is negative. Some of them were transient and then resolved. Review of system, as we discussed in the HPI, past medical history was already pertinent for hypertension, polycystic ovarian syndrome, and history of sinusitis. On physical exam, patient looked pretty benign, no focal neurologic deficit, and did not find too much findings. Lab-wise, this patient tend to have high inflammatory marker. You can see that her SID rate was high, barely high. CRP was 1.3. At one point in the past, she has had a SID rate up to 60. Patient has had high immunoglobulins, and you can notice her total IgG is high and IgG2 is high. Notice IgG4 is normal. Her urine analysis showed normal urine. On the CT of sinuses, we did find a mass. So there was a mass at the right middle meatus of the ethmoid, roof of right maxillary sinus, and it was eroding into the lamina propria to form an extracorneal mass in the right orbit. So at that time, autoantibodies were checked on the patient. ANA was negative, NCA was negative, rheumatoid factor was negative. So at this point, because this mass looks so irregular and it's eroding into adjacent structures, there was a lot of clinical suspicion of possible malignancy. So what is the possible diagnosis? This could be malignancy, this could be infection, this could be a patient with formerly called Wegener, now called granulomatosis with polyangiitis, easy to say GPA, sarcoidosis, or inflammatory mass. We started to do some workup on the patient, MRI of the head, CT of the chest, abdomen, pelvis. So all those things that I have given you as option, what next step you will do to diagnose the patient, were actually done on this patient. This all workup is being done by the internist, by the hospitalist. With a suspicion of malignancy, this patient actually was seen in MD Anderson. And patient had an endoscopic sinus surgery for the removal of the large part of that mass. Up till now, this patient is very anxious, thinks that she possibly has cancer. She's going to need treatment for cancer. Biopsy is done, and it shows chronic lymphoplasmacytic inflammation and focal storiform fibrosis. Staining was done for IgG and IgG4, and it was positive in the plasma cells. So what is going on with this patient? This patient has IgG4 related disease. That's the topic for today. So IgG4 related disease is a newly recognized fibroinflammatory condition which is characterized by tumefactive lesions. So these lesions look like tumors, they look like malignant, but it's actually a dense lymphoplasmacytic infiltrate which is rich in IgG4 positive plasma cell. There is a characteristic storiform fibrosis that you see in these patients, and the key part to remember, or the take-home message to remember, that they may not necessarily have elevated serum IgG4 elevation. 30% cases may just have histopathologic evidence and not have the presence of elevated IgG4 in their serum. So at that time, this patient was referred to me, and I was told by one of our colleagues, would you see IgG4 related disease patient? And I said, sure. And then I started patient on immunosuppression, and we will talk about the hospital course of the patient in a minute. So let's talk about IgG4 related disease. So we think that this disease has been here for many, many years. Nowadays, rheumatologists have a big interest in looking at IgG4 various manifestations. We have also started noticing that there were conditions that we treated 2 decades ago, and as I will show you, some of these conditions were actually recognized almost 130 years ago. So we knew about these conditions, we just didn't know what was causing it. And now we know that the links have been connected and we can solve the puzzle. But solving the puzzle is what something, as a rheumatologist, the dream come true for me. So we'll talk about the epidemiology of this disease, we'll talk about the history of this disease, we'll talk about the pathogenesis of the disease, clinical features, diagnosis, differential diagnosis, how we manage these patients, what would we do to monitor these patients, and what is the prognosis in these patients. So epidemiology, at this point, we cannot provide sufficient data because many of us didn't even know IgG4 related disease exists, and it has so many manifestations. So it is in infancy right now to figure out how many patients of IgG4 we are all coming across and missing on them. So first it was recognized by Japanese. In 2001, they discovered that IgG4 is upregulated, or it's present in patients with autoimmune pancreatitis. And after that, we have to discuss how rheumatologists stumble on that and how they figure out that we are seeing a lot of patients with IgG4 related disease. So after discovering that autoimmune pancreatitis is related with IgG4 related disease, the incidence in 2007 was 2.2 cases per 100,000, and then it rose to 4.6 cases per 100,000 in 2011. This is a disease of middle age. So in autoimmune pancreatitis world, you're gonna see 55 to 59 years age patient, mostly elderly males, and you can see there is a slight predominance of the male to female ratio. IgG4 can also cause multiple other organ involvement. It can cause hypophysitis. So pituitary can be involved. In those patients, the median age would be 62 years. And it's again a male predominant disease. IgG4 related disease can also involve brain, and patients can have pachymeningitis. Median age is 53, and 65% of cases reported are men. IgG4 related orbital disease. Male to female ratio has been considered normal in the past, with a mean age being 50 years in Europe and 61 years in Japan. But now we know that we are seeing slightly more female predominance, at least in North America. Let's talk about the history of the disease, because it's very interesting how long we knew about IgG4 related disease and the manifestation of the disease, and it took us almost 130 years to link everything together. So 1892 was first time when Professor Dr. Mimicker described a condition with symmetric swelling of the lacrimal gland, parotid, and submandibular gland with massive infiltration of mononuclear cell. So we know about this condition since 1892. The next one is a condition which was described by a German oral surgeon named Hermann Kutner. It's called Kutner Tumor. That was described in 1896, and Dr. Kutner saw that patients come with chronic sclerosing salivary gland involvement, especially the submandibular gland. 1961, we started recognizing that there is hypergammaglobulinemia with pancreatitis. 1967, the first term of multifocal fibrosclerosis was coined, and that time we saw that these patients had retroperitoneal fibrosis, mediastinal fibrosis, sclerosing cholangitis, Rydell's thyroiditis, and pseudotumor of the artery. Talk about multisystemic disease. So how many organs are involved here? 1991, we started recognizing that there is a tumor-like condition with pancreatitis, which is more sclerosing. 1995, the first term of autoimmune pancreatitis was proposed. 2001 is the first time when Japanese described that patients with autoimmune pancreatitis have IgG4 elevation. Since then, for next coming few years, we all thought that this was much more of a GI problem. This was much more of a gastroenterology problem because we just had autoimmune pancreatitis patient. But we started noticing that patients with multifocal fibrosclerosis also have IgG4 elevation. So the most interesting story about rheumatologists getting involved in IgG4 related disease is that one of the US expert in IgG4 related disease, Dr. John Stone, saw a patient with lymph gland swelling and parotid swelling and got a lymph node biopsy. Biopsy was sent to the pathologist, and pathologist reported it way later and said it looks like autoimmune pancreatitis in the lymph gland. So then we started recognizing that it is involving many other organs, and the organs which sometimes typical for presentation for our conditions like Sjogren's syndrome. So this is a picture from 1892 from Professor Dr. Mikulicz, which is showing the Mikulicz syndrome. And you can see patient has marked swelling at the level of the salivary glands. Let's talk about the pathogenesis of this disease. So a lot of advances have happened, and we are still working at this point for the future therapy for medication for these patients. There is a big paradigm shift in rheumatology from working on the innate immunity rather than acquired immunity to get the patient better, because we have started noticing long period of time we've been treating the symptom, not the cause. And knowing the pathogenesis of the disease, and I know it's going to be a little difficult to go through all this pathway, but we want to remember what the pathway shows so that we can target the therapies in future for this condition, which is complex and has so many manifestations. So the theory about the easier way to describe, to quote some other rheumatologists, that this condition is a T and B cell dance. T and B cells are trying to interact with each other and causing the problem. And what you are noticing that the patient has an antigen here. We don't know what the antigen is. There have been a lot of speculations about antigen, about laminin and Nexen, but we don't know exactly what the antigen is. But that antigen is taken by the B cells and plasmablast, and then it causes some activation there, and it, in the presence of MHC class 2, is given to the T cells. The T cells that have been discovered in these patients are called CD4 cytotoxic T cell, and these cells are supposed to be pathogenic. So when these cells get activated, that's creating the cytokines. Cytokines they are secreting are interferon gamma, IL-1 beta, and TGF beta. And we know TGF beta is the one which promotes the fibrosis. And when you look at these patients, the biggest morbidity comes from fibrosis. When they have fibrosis, it's irreversible disease. Damage is done. We also notice that in the interaction of T and B cell, there is role of this thing called SLAM-F7. It's a receptor molecule which helps B cell and T cell to interact. We also know that in this whole pathway, there are T follicular helper cell which are present here. What they are doing is they are helping with the class switching, and they are making these plasma cells to become long-lasting. That leads to upregulation or production of more IgG4. So that's the main pathogenic mechanism in this disease. Why do we care about all these mechanisms? Because we know we're going to develop targeted therapies against them. So this is the repetition of what we discussed. Antigen-driven disease, we don't know what the antigen is. We know there is interaction between the B lymphocyte and T follicular helper cell and CD4 T cytotoxic T lymphocytes. We know that these patients will have ultimately abundant CD4 cytotoxic cell in the tissues. They do have activated plasmablast in the peripheral blood. And this continuous antigen presentation and this polyclonal expansion of the B and T cell is what's leading the further manifestation of the disease. And the cytokines are leading ultimately the TGF beta store from fibrosis. So one would think, well, okay, if we know all that is happening, we are thinking IgG4 may be the main culprit here. Interestingly enough, we have also figured out that IgG4 is not a pathogenic antibody. It's basically an antibody which does something called FAB arm exchange. So it does not cause that much pathogenesis. It is actually antibody which is going to the tissue site and going and binding those antigens which are inciting the disease. So it's being used as an antigen sink, and it's trying to bind those antigens which are causing the problem in the body. We also know that IgG4 antibody has a weak affinity to complements and Fc receptors on the effector immune system like macrophages. So another proof that IgG4 may be a bystander there and trying to just clean up the antigens, but is not causing the main pathogenesis. We also see that 40% of these patients have eosinophilia and IgE elevation. And at this point, we're still trying to figure out what's the role of eosinophils and IgE in the disease. Now let's come to the varied clinical manifestation of this disease. When I look at it, and I definitely have seen patients with IgG4 related disease, it was interesting to see how many other organs have been involved with IgG4 and various case reports that I was able to find. So IgG4 is a multisystemic disease that we were not that aware of, and we can see it can affect body from head to toe. Pancreas get involved, biliary tree can get involved, salivary glands can get involved, periorbital tissues, kidneys, lungs, lymph nodes, meninges, pituitary, brain parenchyma, aorta, pericardium, thyroid, skin, breast, and prostate. So there is no organ left where IgG4 is not, the IgG4 related disease cannot manifest. So this is the metaphor which is given by Japanese, that actually IgG4 was a crow which was flying in the dark night. So none of us knew that that crow was flying. And now once we can see this crow in the daylight, see how many manifestations you can see. We talked about most of them, and we're going to discuss some of them in detail in a minute. So let's talk about them one by one. IgG4 related disease, autoimmune pancreatitis. The first thing that we got to know, type 1 autoimmune pancreatitis. That can happen in these patients who are presenting with abdominal symptoms. Abdominal symptoms are milder without the fulminant acute attack of pancreatitis. These patients also can have sclerosing cholangitis sometimes. Patients can present with obstructive jaundice. The imaging on these patients are interesting because they can have either a diffuse enlargement of pancreas, looking like a sausage-like pancreas. They can have segmental involvement. They can have focal enlargement. They can sometimes have rim-like enlargement around the capsule. And sometimes you can just see some masses there. And the biggest concern, the first thing that will come in mind is probably is malignancy, but maybe a patient with IgG4-related disease. If we do endoscopic cholangiography, you may see beaded and long stenotic biliary duct. So this is abdominal imaging showing a sausage shape with arrows pointing toward a sausage-shaped pancreas. So there have been patients who have gone through full-blown Whipple procedures with concern that this is the cancer in pancreas and were found to have IgG4-related disease and autoimmune pancreatitis. So that's where it becomes more and more relevant to rheumatologists. So this is a patient with the lymph gland and salivary gland involvement. So patient who comes with that bad salivary gland, submandibular gland involvement, the first thing that comes in rheumatologist's mind is this is Sjogren's syndrome. This is lupus. But this could very well be IgG4 related disease. We do see this kind of lymph gland swelling in sarcoidosis sometime too. That's called Hereford syndrome. We can also see this kind of swelling in patients with HIV. Then it's called DILS, diffuse infiltrative lymphocytic syndrome. So you have a wide differential in those patients. But when you see somebody with lymph gland swelling or salivary gland swelling together in a patient like that, you will definitely think of patient with IgG4 related disease in your differential. IgG4 related respiratory disease. So these patients can have, as we said, 40% patients will have eosinophilia, IgE elevation. So those patients may even have asthmatic symptoms. They may have ongoing symptom of sinusitis. Sinusitis symptoms which are too bothersome and not getting better. There can be thickening of bronchial walls. There can be bronchial tumors. There can be airway stenosis. Hilar and mediastinal lymphadenopathy can happen with IgG4 related disease. Mediastinal fibrosis can happen, and we have seen patients with idiopathic fibrosing mediastinitis not knowing what we can offer to these patients. They very well can be IgG4 related disease. These patients can present with mass-like lesions like inflammatory pseudotumor of lung, dense irregular infiltrates can be there, ground glass opacities can be there, and non-specific interstitial pneumonitis like picture can present. And we have seen patients who with IgG4 related disease in which we put them on immunosuppression and their lung fibrosis started improving. Pleural thickening can happen, masses or effusion can happen. If we do bronchoalveolar lavage in these patients, it will show lymphocytic predominance. Transbronchial biopsy may not be adequate to make the diagnosis in these patients. Also, one biggest concern is that patients who have IgG4 related respiratory disease, they can have hidden malignancy, so it can sometimes behave as a paraneoplastic syndrome, so they need thorough screening for lung cancer. Kidney disease. So IgG4 related kidney disease is something that we certainly have seen and co-manage those patients with nephrologists. And IgG4 related kidney disease has two kinds of manifestations. Patients can either present with tubulointerstitial nephritis, then they will have decreased renal function, mild proteinuria and hematuria, or they can present with frank nephrotic range proteinuria and they have membranous glomerulonephritis. Patients can also have renal pelvic lesions, which will be IgG4 related pyelitis that can happen. In these patients, serum IgG4 levels are usually very high with renal disease, and they can also have IgE elevation and eosinophilia. Low complements is something also which we can see in these patients, and that tends to correlate so well with interstitial nephritis as compared to patients with glomerulonephritis or membranous glomerulonephritis. Sometime in these patients, if you obtain CT, you may find that they have solitary lesions in the kidneys. And these patients have undergone nephrectomies and were, because the concern was malignancy, and found out that this is a patient with typical histopathology of IgG4 related disease. So this is a picture of immunofluorescence, which is showing the IgG4 stain positive in a patient with IgG4 related disease. This patient has a membranous glomerulonephritis too, and this PLA2R stain is used to check for primary membranous GN, and that was negative. Coming to IgG4 related retroperitoneal fibrosis and periotitis. So 9.6 to 27% of the cases have been described. Abdominal, back, flank, and lumbar pain can happen in these patients. Lower extremity edema can happen, decreased urine output, low-grade fever, appetite loss, and weight loss. These patients can develop pretty bad hydronephrosis. So when I was a fellow, I saw a bunch of patients with retroperitoneal fibrosis. We treated them with steroid when we thought steroid was doing some job and used as a thiopurine, and they didn't know better. And now we understand that this spectrum is also linked with IgG4 related disease, and there are more therapies which are available to them. The key is to act fast. Once they have fibrosis, damage is done. The fibrosis means irreversible damage. You will not be able to help them that much, so we have to diagnose them early and treat them early. IgG4 related eye disease. So those patients who present with IgG4 related eye disease, we have co-managed those patients with our ophthalmology colleagues, and we have sent patient, they have always sent us patient orbital pseudotumor that we manage with them, and we noticed that in these patients immunosuppression works. Dacroadenitis, which is part of Peckel's disease, can happen. We saw 172 patients with orbital disease who had IgG4 related disease. They had eyelid swelling, they had proptosis, orbital pain, diplopia, and reduced visual acuity. Involvement of infraorbital nerve is also a key feature. The distinction between sinus disease, as we had in my patient that was having erosive sinus disease and it's eroding into the cribriform bone, orbital disease luckily is not that erosive. But we do see patients with orbital pseudotumor and eye manifestations with IgG4 related disease. Neurologic IgG4 related disease. So there are a bunch of syndromes that can be associated with patients with neurologic involvement with IgG4 related disease. Pachymeningeal disease with hypertrophic or nodular appearance of the meninges. You should think of patients with IgG4 related disease. When these patients get complicated, hydrocephalus can develop. Toulouse-Hunt syndrome, I certainly have seen Toulouse-Hunt syndrome patient in the past and didn't know why the patient was being referred to me. Proptosis, diplopia, and retroorbital pain, that can also be a manifestation of IgG4 related disease. Focal motor weakness, sensory loss, and seizures can happen. If eighth nerve get involved, patients can have deafness, vertigo, and tinnitus. Subacute dementia can happen with leptomeningeal involvement in few cases. So one key to try to diagnose these patients, that you can do MRI, it will definitely show the pachymeningitis picture. If their brain mass, it can be seen. But PET is not that helpful because in general, brain has increased uptake in PET scan. So you will need the MET-PET, 11C methionine PET, different kind of a PET to find the pathologic lesions with IgG4 related disease. LP in this patient, CSF will show mild pleocytosis, 200 nucleated cell per millimeter with lymphocytic predominance. We thought that IgG4 related disease was involving everything except brain, but that's not true. We know they have patients have brain lesions too, and we have seen some cases of the brain masses with that. Peripheral nervous system, IgG4 related neuropathy can happen, which involve the visceral nerve of almost any organ of the body. Vasculitic neuropathies can happen with IgG4 plasma cell infiltrate. So this is a picture of a patient with pachymeningitis. You can see all the dural thickening and hypertrophy here in this patient. It's visible here. And then the biopsy is showing the classic infiltrate, and then it also showing the positive IgG4. We're going to talk about histopathology in a minute. IgG4 related hypophysitis. So patient can present with involvement of the pituitary gland, and they can have symptoms of central diabetes, diabetes insipidus, hypothyroidism, hypergonadism, and this all happened because they had their pituitary involved. You can have headache, fever, weight loss, lethargy, hypersomnia, and fatigue. And when you do MRI in these patients, you will find that pituitary looks inflamed. Patients can present with the full pituitary failure. And this is another entity that we have known for a long period of time, and now we know there's a link with IgG4 related disease. So once we saw all these clinical manifestations and a radiologic finding on a patient, when we start suspecting IgG4 related disease, it would be always based on the clinical features and radiologic features. But once you start suspecting somebody has possibly IgG4 related disease, couple of things we can do. We can check the serum IgG4 level. So when you order IgG in Epic, it will give you two options. One is which is just IgG, and other is IgG 1, 2, 3, 4. So the other one, IgG 1, 2, 3, 4 is the subtype, and when you're trying to look for elevated serum IgG4, that's the test you want to order. It's a send-out test, so it looks like it's a very expensive test. It costs less than $50. So if you're interested in looking at IgG4 level on a patient and you think this might be IgG4 related disease patient, by all means, go ahead and order the test. Histopathology, so once you have involved organ in a patient, you can get the biopsy. When you get biopsy, it will show changes which are very characteristic of IgG4 related disease. There would be a lot of lymphocytes. There would be a lot of plasma cells. There would be obliterative phlebitis, which is the obliteration of the blood vessels by the infiltrate of those inflammatory cells. These patients can have eosinophilia there. Now, one caveat to keep in mind is if you think this patient has IgG4 related disease, you should ask for the immunohistochemical staining. It's not routinely performed. It has to be asked for. So if you find out that this is how the biopsy look like on histopathology, you must ask for IgG4 stain. And the patient who are IgG4 positive, their plasma cell, more than 40% of them will be positive for IgG4. So this is the classic histopathology of a patient with IgG4, and you can see the arrows are pointing toward a lot of infiltrates, and it's showing the blood vessel which lumen is obliterated with the inflammation. You can see this pink thing all here is the fibrosis, in the storiform fibrosis in the patient with IgG4 related disease. This is the special stain, immunohistochemistry stain. You can see that all these arrows are pointing toward the positive IgG4 stain. And those patients who have more than 40% of that, that's the diagnostic criteria. What is the differential diagnosis of IgG4? So there are so many things which come in the differential diagnosis of IgG4 related disease. Malignancy. So because this disease is known to cause tumors in so many parts of the body, so first thing that will always come in mind, could it be cancer? And definitely we'll reach out for biopsies for those patients to make sure that we are not missing out on malignancy. Infections, so TB, syphilis, HIV, fungal infections, they all have chronic lymphocytic infiltrates, and so you would like to check those and make sure that we have ruled out infection. From inflammatory conditions, and that's where my life gets harder to diagnose these patients, is Sarcoidosis mimics like that. Sjogren's syndrome can present like that. Vasculitis. We should take a minute when we're talking about vasculitis can mimic IgG4 related disease. That nowadays more literature is coming that in patients with formerly called Wagner's and Chugstrass, now called GPA and eGPA, there may be coexisting of IgG4 elevation in these patients. And we're trying to find a link between both. But you should also differentiate that the patient may be ANCA-associated vasculitis if they have just sinus problem going on, and then they may have other features like pulmonary hemorrhage. Multicentric Castleman's disease is another condition which can mimic IgG4 related disease, but in this condition we see high inflammatory markers, IgA is elevated, and they tend to have less fibrosis, and they're treated with IL-6 blocker therapy called tocilizumab. Rosai-Dorfman disease is another condition which tends to cause a lot of tumors in the body, but it has histiocyte excess. But that comes in the differential too. So there's a wide range of differential that you will have to rule out where you're trying to figure out and make a diagnosis of IgG4 related disease. And this gives you the idea of how great of a mimicker this disease is, that it can mimic all these conditions. How do you treat these patients? It depends upon the severity of the disease. We saw it's so multi-systemic. We saw so many organs are involved. So first line treatment always would be steroids. And then in patients who have had good response to the treatment, if they do not have very major organ involvement, sometimes you may just do DMARD like azathioprine, methotrexate, or mycophenolate, Moftel. If you see patients with only lymph gland involvement, sometimes you may just observe them too for a while and just do all the workup. But if the patients have vital organ involvement, they are having extensive disease, they're having recurrence of the disease, or they're having refractory disease, that's the time you have to put them on B-cell depleting therapy with rituximab. So we have seen big advance in using this medicine in these patients with IgG4 related disease. When patients have advanced disease and they've been untreated or refractory, sometimes they will have that much fibrosis, they may need surgical debulking. They may need stenting due to the fibrosis. That is, stenting is something we commonly see in patients with retroperitoneal fibrosis. The sad part about seeing those patients with retroperitoneal fibrosis that I always felt bad, I saw them most of the time when their kidney function was already pretty bad. And we knew that there was so much fibrosis there, and we tried to just use steroid, and we were not able to make that much of a difference. What are the future therapies for patients with IgG4 related disease? So work is ongoing because we would want to get better in treating the condition. At least now we know the pathogenesis, and at least we now know that how many conditions are linked with it. So there is a great interest nowadays on the CD19 inhibitors and blockers that hopefully will block that, and that will help, because the real concern always stays in the mind. We have patients who are Rituxan intolerant. We may find a patient who is refractory to Rituxan. What would we do next? So that would be the greatest challenge in those patients. So CD19, BTK inhibitors are some future target therapies for patients with IgG4 related disease. Elotuzumab is a medicine that at this point the concern is if we can get that SLAM F7 be targeted, and remember this is a receptor which is helping the B and T cell to interact with each other. If we can close that, if we can break that, the interaction of B and T cell, we may have a success in the future. Abatacept. Abatacept is a medicine which is called Orencia. It's a T cell co-stimulatory inhibitor molecule. And one of the concept in mind is that if we do that, maybe we will block the T cell activation. And as we know that in the disease site, we saw most of the CD4 cytotoxic T cells. So we block that, we may be able to have improvement in these patients. So that's one of the other future therapies. And the abatacept Orencia has been widely used for rheumatoid arthritis patient and for psoriatic arthritis patient. How would you monitor these patients? So that is a challenging thing, because as we discussed, IgG4 is not pathogenic in itself, and it's probably not causing the disease. It's just trying to buffer those antigen and acting as an antigen sink. Would it still be a good marker to look for monitoring for disease if disease is responding to the treatment or not? And when is patient flaring? So what we know so far that it's elevated in 60% of patient at diagnosis. 63% cases will not normalize it with remission. But those patients make you nervous because their IgG4 is still high. That means they will keep getting the redosing of this medication. because antigen exposure is still there. That's why this IgG4 is still upregulated, staying there. And level increase only in 10% after relapse. So we have some more markers which we can look at. I'll show you in a minute how you can look at a patient, not only IgG4 but other markers to give you an idea how the patient flares. Serial monitoring of these markers and serologic markers, along with that serial imaging monitoring is another way of looking, because if you're looking at pancreas, you're looking at retroperitoneal fibrosis patient, even lung involvement, you would want to get serial imaging to see if there is progression of disease or not. Complement level is something, so this is interesting that kidney disease has two manifestations, membranous GN part and the interstitial nephritis. And literature shows that complement level is what they have seen correlating well with the flare of the interstitial nephritis. Membranous GN complement level would not help that much. So in those patients, we're trying to see other things too. I will show you in a minute. So this is a patient who got into remission and has kidney disease also, and now presents with a flare. So you notice what happened with the flare in the patient. Albumin started going down. Globulin starting coming up. Complements which were normal, they have dropped down. And we can see that we can use IgE also as a surrogate marker for the flare, because you see in this patient IgG4 rose significantly, but IgE is also elevated. So that may be another way of monitoring this patient when you're looking for the disease flare. Prognosis-wise, what is the prognosis of this disease? Since we didn't even know how many of these conditions are linked with IgG4 related disease, our data is very limited right now. But we know patients can have kidney involvement, heart involvement. I have seen cases of pericardial effusion with constructive pericarditis with patient with IgG4 related disease reported in literature. So aorta involvement, pancreas, lung, CNS involvement, all those are major organs. So if patients not treated on time, they will have bad outcome. Other problems that you will run across is that these patients are middle-aged men. So we are giving these patients who already have atherosclerosis risk factor tons of steroid before we knew what else we can do for those patients. So they can have more hypertension, steroid-induced diabetes or type 2 diabetes, coronary artery disease, osteoporosis, and risk of infection. There is also a threefold high risk of malignancy in these patients, whether solid malignancy or hematologic malignancy. And when I was pondering on that, hematologic malignancy makes sense to me because they have so many plasma cells. So they can have plasma cell disorders and lymphoproliferative disorder, but they tend to have some high risk of solid malignancy too. And I would say once we have more data available, we will notice this happens more in untreated patients. But we have to keep a watch on that. They can develop malignancy in their course of the disease. So let's look at what is the cumulative damage from this disease. Patients can have exocrine pancreatic failure, they can have endocrine pancreatic failure, they can have renal failure, they can have hydronephrosis and chronic ureteral stents with a lot of morbidity, chronic hepatobiliary failure, they can have bony destructive lesions in their sinus and look like GPA or Wagner's, they can have orbital lesions and have permanent vision loss or reduced extraocular movement, they can have pituitary failure. So how many systems we got covered here and how many specialists will be involved in these patients? Many of us, all of us. And primary care and internists will. Actually, primary care and internists would be at the forefront to first recognize those patients. So for the time's sake, I didn't want to put that, but I could not resist to put the classification criteria. 2019 is the first time they did international consortium was made for IgG4 related disease, in which rheumatologists and many other specialists participated, and they found 1,879 patients, and among them 1086 were the typical IgG4 related disease patient, and they come with the inclusion and exclusion criteria to help us make the diagnosis right. So the first requirement was that patient will have typical organ involvement, which could be pancreas, bile duct, orbits, lacrimal gland, salivary gland, retroperitoneum, lungs, kidneys, aorta, pachymeningitis, and thyroid gland, thyroiditis. What are the things which made them exclude people from the disease? When they have fever, we know this is an indolent disease, and patients sometimes would not have that classic B symptoms there for sure. If patient does not respond to steroid, this may be something else. Leukopenia and thrombocytopenia points toward more other conditions like Sjogren's syndrome, lupus. If patient had very predominant peripheral eosinophilia, more than 3,000, you're talking about patients like Schwarz-Strauss. If patient had NK antibody positivity, if the patient has anti-Rho and La positivity, now we know there may be Sjogren's syndrome or NK-associated vasculitis. I want to say this NK positivity may change in future because we're seeing the coexistence of NK and IgG4. Rapid radiographic progression. We are saying this is an indolent disease. It takes a while for it to progress. So if something is happening very rapid, you will exclude them, and you will think that's a mimicker of IgG4-related disease. And there's three important things to remember in mind. If they have much necrosis and necrotizing vasculitis, it can't be IgG4-related disease because the features are more fibrosis, not necrosis. Prominent necrosis, they removed the patient, necrotizing patient were excluded, they were called mimicker granulomas. So once you find patient with tumor-like lesions and it has granuloma there, you can automatically start thinking of sarcoidosis. So these were things that they use. If patient has histocytic involvement, then they may have conditions like Erdem-Chester disease, they may have Rosai-Dorfman disease, they may not have IgG4-related disease. So, and this consortium thinks that this criteria and classification criteria work very well, and they found in the first validation cohort, or 908 patient, found a specificity of 99.2% and sensitivity of 85.5%. With the second validation cohort with 485 patients, they found a specificity of 97.8% and sensitivity of 82%. So coming back to my patient, what happened? So a patient was started on 8 weeks of prednisone taper with improvement of her symptom. 3 weeks after completion of prednisone taper, her sinus symptom returned. By that time, this patient was so mad at me because she had gained weight with the steroid and she didn't want to even come back to the appointment. I had to discuss with her, put her on rituximab. She's off of all steroid now. And repeat imaging, I did the CT of her face, CT of her brain, and there is complete resolution of that eroding orbital mass. So what we want to remember in summary in these patients, IgG4-related disease is a relatively new disease entity that has been described, but keep in mind it has so many syndromes and conditions that we have known since 1892. We just didn't know better that they are all linked to IgG4. This disease can affect almost any organ in the body. Disease is indolent but very destructive. And involved organ have similar features, tumor-like swellings, and there would be lymphoplasmacytic infiltrates. There would be IgG4 positive plasma cell. There would be fibrosis in the form of storiform fibrosis. Remember, IgG4 positive staining would be done on request. It's not done on routine. Patient may have elevated serum level of IgG4, but normal IgG4 level, but typical clinical features would not rule out the disease, so keep a high index of suspicion. These patients respond well to immunosuppression, and this condition is thought to be autoimmune process now. And we will need more research to find more steroid-sparing agents because we definitely need more because there's so many organs which are involved. And it's being saying, it is all over in our literature nowadays. American College of Rheumatology, EULAR, which is the European League Against Rheumatism, their literature is talking about IgG4-related disease. It's been called the greatest mimicker of our century. Our January issue or journal from ACR is saying that it's a medical marvel of our history. So as a rheumatologist, it's very fascinating for me to be trained and working for so many years and not knowing about a multisystemic disease. So we're seeing history and evolution that we're getting to know about another multisystemic disease in our life. And hopefully we will also get to know more treatment option for this disease in future. These are my references. Thanks for coming and listening, and I'm happy to answer any questions.